So thank you very much, everyone, for inviting me. So what I'd like to do is to talk about something on which I don't have any great expertise, but something I was asked to talk about last year, actually to a large audience of urologists. And forgive me, the urologists in the audience that have heard what I've got to say, although I've modified it slightly. So I took the opportunity really to review what I could understand of the data linking cardiovascular risk and disease with renal stones. So really the question for me was, and still is, there clearly is an association. I'll show you the evidence for this in just a moment. But of course, we do know that many of the traditional cardiovascular risk factors exist in our patients, and of course they exist as they get older, and that may be an important factor. But of course there is evidence, as I mentioned, to show that stones in themselves seem to be connected in some way to hypertension, which is of course in itself a cardiovascular risk factor, and to chronic kidney disease, which of course also brings with it cardiovascular risk. So the question is, for me, what is it real? So is this association a real association? And is there something underlying it? I mean, is it really independent of just an association of cardiovascular risk factors in an older population? So what might the mechanism be? So can we get any insights or thinking around that? And what all can we do about it? So I think probably one message I'll give you at the end is probably at least we should bear in mind that our patients with renal stone disease are at greater cardiovascular risk. So it should at least highlight us to consider that association and look at risk modification in those patients. So if you go through the literature, you look back actually, and you find that the first documented association, at least reported association, was back in the early 1970s. Several publications at that time linked renal stone disease to cardiovascular events. At that time, there was some controversy as to whether there really were differences in cardiovascular risk when they did a control population, again in an older population, particularly in males. And also there was some link to vitamin D at the time. They thought there was some association with vitamin D. But as you can see, over the years since, and particularly in the last 5 or 10 years, there have been many, many publications now that have linked renal stone disease to cardiovascular risk or events, myocardial infarction, if you like, a reflection of cardiovascular risk, carotid thickness, been a number of meta-analyses with the cautionary note that Thomas cited, which again have indicated a link, either stones themselves or surrogates like arterial stiffness for cardiovascular risk or carotid thickness. Interesting enough, a number of the more recent ones have suggested that this is more in women than in men, and we heard a little bit about that from Gary in a slightly different context. And a very recent publication here, another meta-analysis, again showing this link, but this time suggesting that there was actually stroke more associated, and again, more in women than in men. But these are all retrospective analyses. So we have a similar story for hypertension, which has been going on for many years as well, although the debate has always been, is it stones and hypertension, or is it hypertension leading to stones? And of course, we know there are links to hypercalciuria, hyperoxaluria, hypercituria, and increased body weight. Again, a number of publications over the last few years. Something more recent in the context of chronic kidney disease, again, has been thrown up. Again, this looks as though it might be more common in women than in men. So you can see there have been a number of these associations that have been reported in the last decade or so. But, as you all know, association is not causation. So the question really is, what underlies this? And is it really just a coincidence with age, so comorbidities? Well, I mean, it's quite difficult. There are many additional risk factors which are linked to this. So the recent publication of a few years back now by Rule showed that about 60% in adults with stone disease there was more atherosclerosis, there was more myocardial infarction, and this appeared to be independent of chronic kidney disease or the serum lipids in that publication. We know, however, that many of our stone patients have risk factors such as increased BMI, which of course run with it high blood pressure, diabetes, gout, all of which we know are in themselves associated with cardiovascular risk. And we know that BMI has been increasing steadily over time. We also know in younger adults there's an association being reported between stones and atherosclerosis. We know also there's been an upward trend in uric acid stone formation over the last few years. There's a general tendency, more acid urine, more uric acid stones relative to calcium phosphate stones over time. So again, we know that uric acid, urate in itself, certainly by some is believed to be a cardiovascular risk factor. And you know I'm moving us all in the direction of the metabolic syndrome, which we know is associated with renal stone disease, and we know in itself carries cardiovascular risk with obesity, hypertension, diabetes, dyslipidemia, and atherosclerosis. If you look at the cardiovascular events, again, this is from the Rule publication, you can see that the events are cumulative for stone formers relative to non-stone formers. If you look at the difference between stone formers and control subjects, you'll find many of the other risk factors that we know are linked to cardiovascular risk present in the stone formers, with more renal impairment, more hypertension, more diabetes, obesity, dyslipidemia, and gout, although not more alcohol dependence or tobacco use. The same applies to hypertension. Again, we see there's a stronger association or prevalence, this is a cumulative incidence, in stone formers compared with non-stone formers. And even if you adjust for many of the cofactors that you might find with hypertension, you still get really a strong association. So this link appears to be independent of stone type, so it's not confined to uric acid stone formers, for example. And it seems from this study, at least, that prior hypertension doesn't predict stone disease, so it doesn't seem to be hypertension followed by stones. This is another study that looked at stones. Again, of course, this is not a study designed to look particularly at stone disease, but looking at atherosclerosis. This is the ARIC study. And again, CV risk factors were much more prevalent in stone formers compared with non-stone formers. So in this study, there was no increase in CKD in this population. But again, reinforcing this link. You've heard this before, a little bit from Gary, and this is the work of Manuel, looking really at stone risk and CVD in a larger study, a larger cohort in the HPFS, NHS 1 and 2. And again, in stone formers versus non-stone formers, the rate of cardiovascular events was significantly higher. And remember that the NHS 1 and 2 studies are female, and the HPFS is predominantly, or is male. So again, this is an important link. You saw this from Gary, again showing this link in association, but this time again showing that it actually didn't really bear out so strongly in men as it did in women, we looked at in more detail. So again, the strong association. We're also seeing a general trend now, which is a little bit alarming, increasing incidence and prevalence of pediatric nephrolithiasis. This is the South Carolina cohort with a steady increase over time, again, particularly in females relative to males. And this is a Mayo Clinic cohort showing much more stone in those between 12 and 17, so in the young adolescent population here. And stones are now accounting for around 1 in 700 pediatric hospital admissions. And again, there's a similar trend for obesity and type 2 diabetes. Again, further evidence now in relatively young patients that there's an association between stones and atherosclerosis here. So this is a measurement of carotid artery intermedia thickness in a pediatric stone formers. Again, so you'd think that there's something going on very early in life, so it's not an age-related question here. And that in this study there was an interesting relationship between carotid artery intermedia thickness and osteopontin excretion. There was a direct correlation. So what could this mean? So can we make some connection here in relation to osteopontin? So osteopontin has also been highlighted in the context of Randall's plaque, shown here. So there's quite a lot of osteopontin expression in the plaque material, and EM shows expression within and around plaque. There's also an old association between osteopontin gene polymorphisms with stones, both calcium, for calcium stones, calcium oxalate and calcium phosphate. So what of osteopontin? Well, osteopontin is one of these molecules that seems to have a dual effect. So it certainly is pro-inflammatory and has been linked to atherosclerotic plaque stability. So there is definitely a link there. But also it's inhibitory and has important effects in relation to vascular calcification. So it has an inhibitory role in vascular calcification, but it has a pro-inflammatory role. And this appears to depend on which fragment you have. So there's something in the osteopontin story, perhaps. This is an interesting paper published last year looking at the top upregulated and downregulated genes in Randall's plaque, so taking Randall's plaque from patients. And a couple of things come up here. One is lipocalin-2, which is known from previous studies to correlate with cardiovascular risk in itself. And this one here, monocyte to macrophage differentiation associated factor, which is another inflammatory marker. So you've got a general inflammatory state in these patients. So certainly there is a consistent, I think, link between cardiovascular risk and stone disease, and I think this is really summarizing a number of the publications, in addition to those I've already shown you. I think one question that is of interest, for me anyway, is this cardiovascular risk related to the presence of Randall's plaque? So if we start to look more closely at the stone population, so clearly these studies have simply looked in general. There doesn't appear to be a distinction between urate stone formers and calcium stone formers, as far as we can see, but it's in the generality of stone formation. But one of the interesting things would be perhaps this relationship to Randall's plaque, which isn't present in all stone formers, but could this be a subgroup of patients, and could they be representing really or pushing this cardiovascular risk in particular? So I think that would be an interesting aspect to explore. There's also the relationship to vascular calcification, and this is, as you know, an old study of ours actually, showing that it's already known that patients, or male patients in particular, with renal stone disease have reduced vertebral bone mineral density. That's been known, and also that patients with hypercalciuria appear to be wasting calcium and have a relative loss of calcium. Bone mineral density certainly appears to be lower in stone formers, and that's across the board, not just in males. And this appears to be associated, at least, with aortic calcification. So that is an observation which has been followed and confirmed by others. And indeed, there's another recent publication last year looking at ultrasound-based nephrolithiasis diagnosis and the presence of carotid artery calcification, coronary artery calcification, and showing that this was significantly increased in stone formers relative to non-stone formers. But again, you'll see many of the other cardiovascular risk factors are present in the stone population. So what next? So what can we do about this? How can we investigate this? Because really we're not much closer to the mechanism. We know there's an association which seems to be strong. Well, I mean, you know there's been an interest in these calciprotein particles as a measure of calcification propensity and the role of fetuin A, and this test developed by Andreas Pasch and colleagues looking at the serum 250 score, which is a way really of measuring the ability to resist calcification, and looking at this in serum. And I know this is being looked at in urine in a rather different context currently. But again, there's already data to show that this seems to be associated or linked to measures of cardiovascular risk, mortality, aortic stiffening, myocardial infarction, hospitalizations for unstable angina. I mean, one of the puzzles for me is that fetuin A certainly has an anti-calcification role, and certainly levels are thought to be lower in patients with CKD, and it may be contributing, although that's a bit controversial. But also fetuin A from the metabolic literature is actually a cause of insulin resistance and is associated with a metabolic syndrome. So how we can reconcile this metabolic syndrome story with cardiovascular risk and stones and the fetuin, I'm not sure at this point, but that's another example. Clearly, this risk is increasing. Those with stones, as you saw earlier, the prevalence is quite high, ranging between 5 and 10%. And this would mean, certainly in the UK, greater than 5 million in the UK would be potentially an increased cardiovascular risk of stone formers. So I think the message really is to pay attention to cardiovascular risk in stone formers and to regard a stone former at increased cardiovascular risk and pay more attention to the modifiable, at least, cardiovascular risk factors that you can manage in those patients, even though we think there's probably some other additional mechanism that is contributing to their risk. So I think we've got to try and put all these bits and pieces together, and this is really going to be a difficult story, but at least we've recognized the problem, and now it's a question of how we can think of understanding the underlying mechanisms. And with that, I'll stop. Thank you.
Thanks, Robert, for this very nice presentation, very exhaustive and so, please, Nilüfer.
Thank you very much for this nice presentation, Robert. So, I mean, we looked at cholesterol and And the cholesterol levels were not increased in this patient, neither regarding sex. So do you think that there is a biomarker how we can assess the CV risk? Because otherwise, how would you suggest to identify those, or how should we look at?
I completely agree. So I mean, my take on this when I sort of was pouring through the literature trying to make the case, really, just to examine this question, was clearly there is this association. It seems to be a very consistent association. It's still unclear to me how much of that is driven by the traditional cardiovascular risk factors, which may be present in both populations, and how much indicates there's some other process. I think there probably is another process, and the thing I was sort of thinking about and came up with was the osteopontin connection, and I was interested in the relationship between the presence of Randall's plaque. So I was wondering whether, getting our urologists in the audience, whether we could improve the phenotype, if you like, of those at cardiovascular risk by looking to see whether there's something special. So we were discussing this morning about how we can better phenotype and how we should phenotype the stone population rather than just say you have a stone or you're a stone former. We can do it to some extent in metabolic terms, but I think probably there's an opportunity to look at something a little more closely, and I wonder whether the Randall's plaque could be another marker that we can use to single out a population of stone formers and see if we can explore this relationship. Do these patients, are they in a more inflammatory state? I don't think that necessarily their cardiovascular risk factors are any different. They might be lipids and glucose and diabetes prevalence. I don't know, but this may be something to explore. So I'm not giving you a satisfactory answer, but trying to think about how to go forward.
Two more thoughts about how to move forward. One is that women seem to be at
So that could be
risk.
another clue, I agree.
So is there anything
Yeah,
there?
I was thinking about that before, and I don't know. I mean, I don't think there's any. I don't know how the sex hormones could be brought into play. I don't know about the age relationship. I mean, you know, there's this sort of bimodal, at least there was this bimodal pattern for stone formation in women, which was attributed to the use of hormone replacement therapy later. You know, they were losing calcium in the second phase, and then people introduced hormone replacement therapy, and it sort of got better and pushed it back. But other than that, I don't know. But I think you're right. I think this sex difference, which Gary highlighted, may be another clue that there's something else going. They do seem to be at greater risk, both in cardiovascular and renal terms, than men, funnily enough.
And then the other question was about stone type. Has anybody looked at cardiovascular disease or events by stone type? Because
Well, there was only that one publication, I think it was the Rule publication, which claimed that the risks that they reported, they could not relate to stone type. So they sort of dismissed uric acid stone, and they were sort of trying to move away from metabolic syndrome and arguing that there's something intrinsic in having stones that is linked to the risk. But that's all I was able to find.
Robert, actually, the Stoller group, Stoller in North America, proposed that the Randall plaques are formed from the vessels. So the Randall plaques could be biopsying a Randall plaque could be a way of biopsying the vessels.
I didn't know that.
Yeah, there is this hypothesis which was proposed some years ago, and this is very interesting. Also because you know our studies in the medullary sponge kidney,
Yes.
And we had the chance to cultivate one papilla from a patient, and surprisingly, this papilla, the sprouting, the cell sprouting from the papilla started to calcificate, and these cells were pericyte. So the pericyte are something like smooth muscle cells.
Yeah.
So we could speculate.
I mean, we definitely need to somehow get into the mechanism, because the association is all very well, and I think that's well documented. But and of course we can pay attention to risk factors in our patients. Focus a little more on the stone patient as having another cardiovascular risk factor. But it's the mechanism that's the real challenge.
And just a moment. The relationship with the women could be because of the bone, because it is known that osteoporotic females have an increased stiffness of the vessels or the aorta.
Maybe, I don't know. I mean, I don't know. Gary would comment on that. I don't know if that's an aspect.
We don't have the data. When my mom did those analyses, we carefully adjusted as best we
Mm, mm.
Yeah, so, but that, yeah, I think that at the population level, you bring that, there's a clear association, and it needs to be
Mm.
resolved more closely to evaluate the patients.
Mm, mm, absolutely.
Robert, did you find any evidence that lack of vitamin K, which is a dietary problem, because you need vitamin K to carboxylate important proteins such as osteocalcin, you get osteoporosis if you don't have it, matrix GLA protein for the blood vessels, and urinary inhibitory proteins need sometimes also vitamin K for the carboxylation to function properly. This may be a link.
Yeah, no, that's an interesting. I didn't come across anything about vitamin K. I confess I didn't look for a connection, but I didn't come across by chance a connection with vitamin K. I mean, I think the other point is that we sort of know this. I mean, in a way, it's recognized within the stone community, but I'm not sure our colleagues outside necessarily recognize that they should, really be alerted to a patient with stones and their long-term cardiovascular risk more than, if you like, the general population. That's what I feel needs to come across as well. But as Gary said, we need to understand why there's this difference. I don't know.
Okay.
Okay,
Thank you, Robert, for